Thank you for the opportunity to present a case that led us from gut to gene to find a diagnosis. This case concerns a 30-year-old woman who presented with diffuse abdominal pain, nausea, and watery diarrhea. She had these complaints for about 2 weeks and suffered from progressive weight loss, fatigue, and muscle cramps. Medical history revealed a long-standing vitamin B12 and iron deficiency. She had an IgA vasculitis since childhood and a possible celiac disease in adolescence. Additional social and lifestyle history was unremarkable. Physical examination revealed high-grade fever, but without neurological abnormalities. Vital signs were still reassuring, and the abdominal evaluation revealed hyperperistalsis, a diffuse tenderness, but no rebound pain. An overview of our blood results and highlighting the mild anemia, the atypical lymphocytes, the electrolyte abnormalities in line with a persistent diarrhea, and an acute renal insufficiency. We also observed cholestasis and a significantly elevated CRP. Abdominal ultrasound showed some pericolonical fluid accumulation, and unfortunately, microbiology cultures and infectious serology, including CMV, were negative. And of course, as always, a PET-CT was performed because of persistent fever. This confirmed prominent pancolitis and a hepatosplenomegaly, but the diagnostic clue was a colonoscopy with a biopsy showing these apoptotic bodies localized at the crypts. And this made us again think of a CMV infection. And indeed, we could stain CMV DNA inside these nuclei, and the serum viral load of CMV was persistently elevated, so we treated her with ganciclovir. 3 months after discharge, she had a complete clinical recovery, but the atypical lymphocytosis persisted. The CMV viral load was undetectable, so we looked at EBV viral load, and to our surprise, this was significantly elevated. We monitored these viral copies over time, but because of a lack of viral control, this required a treatment with rituximab. So now the combination of a CMV colitis and an EBV reactivation is, of course, red flags for an immunodeficiency. First, we looked at these common causes of secondary immunodeficiency, but apart from some mild signs of malnutrition, this was a negative workup. What about the workup for a primary immunodeficiency? There has been some cases presented here. I want to highlight 3 important tests here: B and T cell immunophenotyping, the functional testing in vitro, but also genetic screening when you suspect an inborn error of immunity. So first is immunophenotyping. In this patient, we can see that these T cells were skewed towards an effector phenotype, in line with this chronic immune activation. B cell maturation was normal, but you see this significant dysgammaglobulinemia. Next, we tested the patient T cells on proliferation by exposing them to different antigens. And surprisingly, these T cells were markedly proliferating weaker than healthy control cells. How we evaluate B cells? Well, you can measure antibody production after pneumococcal vaccination, and again, the patient B cells did not produce any antibodies after vaccination. So concluding both these results, this patient has a combined immunodeficiency, and this is a strong indication for genetic screening. And here's the answer for the case. Whole exome sequencing revealed 2 mutations in the SCIF2L gene. Only our patient carried both of these mutations, none of her healthy siblings. What is this syndrome? It's a rare combination of hair abnormalities, neonatal enteropathy, progressive liver damage, but also immunodeficiency. And then this persistent low-grade inflammation during follow-up caught our attention. So what is known about SCIF2L in fundamental research? Well, we know it's hyperactivating T cells, and it gives a type 1 interferon response. So we went to our research lab, and indeed, in serum samples of these patients, you can see this interferon gamma-dominated T cell activation, and you can also see on RNA level a type 1 interferon response. And so finally, the last one was the IgA vasculitis. Could we explain this phenotype? Well, there was an immunodeficiency congress in France last year, and we came across this poster, the exact same combination of these two phenotypes. So currently we are collaborating to investigate if actually gut dysregulation is the main driver of this disease. And this takes me to my final takeaway case lessons, the importance of molecular testing in herpes viral infections. Of course, CMV colitis, EBV reactivations are red flags for an immunodeficiency, and a stepwise approach for diagnosing a primary immunodeficiency. And I want to thank you all for your attention.
Thank you. Who is willing to comment?
It was really very impressive. The clinical conditions that involved different mono and polygenic immune deficiencies are very rare and very complicated to transfer simply to the clinical practice. We know at least 400 such genetic errors of inborn and innate immunity, but using your whole exome sequencing, which involves only 1% of human genome, but this coding sequence is very useful. So I'd like to congratulate you of the sequence of clinical thinking and reasoning which led you to the influence of a very, very rare inherited condition on the clinical situation of 30 years old woman. For many decades ago, these children have died in newborn or early childhood. Now there are persons with forgotten history. So congratulations. Also, this condition has a great influence on the human microbiome in the gut. So it's also one of the conditions which have influence on the clinical course. Thank you.
Yeah. So things I want to comment on that, indeed, our healthcare is getting much better. So diagnosing primary immunodeficiencies at a later onset stage in your life is more and more frequently. And again, this stepwise approach, doing whole exome sequencing with everyone, you can have this variant of unknown significance, class 3. We have a lot of functional tests in the lab, and if you do it stepwise, your yield of your whole exome sequencing will be much bigger. And whole genome sequencing will not change this era, because you will have more data that's going to be very difficult to analyze. So your chance of getting a primary immunodeficiency, it all starts with your clinical picture and the chances of getting a PID. So that's, I think, is very important for this case as well, to do it sequentially.
Congratulations. Did you perform a familial tree, and did you have the opportunity to test relatives?
Yeah, so the family tree, I know it was a bit fast, 6 minutes is very short, I've noticed. There's a family tree, she has 3 siblings, and they only carry 1 mutation. She's the only one who's compound heterozygous. Compound heterozygous because we segregated the gene, mother and father carries 1 gene, yeah. 1
and
mutation.
healthy?
All healthy, it's a biallelic mutation, indeed, all healthy. The clinical clue was her neonatal enteropathy, which is, transient in this phenotype. Yeah.
Thank you. Any more questions? If not, I don't see any. Thank you so much for this presentation.